Welcome to Altea Talks, the brand new podcast series being brought to you by Altea, the unique provider of combined insurance and risk management solutions designed exclusively for the medical, allied health and care sectors. I'm going to be your host, Will Marshall, and I'll be joined in this series by some of the leading movers and shakers from across the sectors. My guests are going to include practitioners and professionals, regulators, clinical risk and governance specialists, and an array of legal experts who are going to help us get to the heart of the hottest topics affecting health and social care sectors today. So, if you're looking for frontline knowledge and expertise, if you want valued insights into these most dynamic, challenging and rewarding of sectors, then look no further because you're in the right place. Welcome again to Altea Talks. Hello and welcome to this latest edition of Altea Talks. This week I'm delighted to be joined by Dr. Alice Ashby in this second part of our special double episode analysing some of the key trends, issues and features affecting the world of psychiatry. Can we start the second episode, Alice, by discussing your experiences in the fascinating arena of maternal mental health, and particularly managing the emotional challenges in that area? Because I know in your career, you've been instrumental in setting up services like the maternity trauma and loss care and expanding perinatal psychiatry services. And can I just ask you, how do you approach providing mental health support for women who are struggling with such huge issues, such as the loss of a wanted pregnancy, fertility difficulties, birth trauma, that sort of thing?
Yeah, really, really important, kind of personally important areas for me. I make no particular secret that my own children are born from IVF. I'm very thankful for that service. So I know kind of personally what it's like to go through, and I guess that gave me a lot of interest professionally. Yes, I was clinical director in West London NHS Trust for Psychological Medicine, which involved building and expanding perinatal psychiatry services there. But I'm most proud of that maternal trauma and loss care service because it was a new idea, and it was directed particularly for people who'd had recurrent miscarriages or fertility difficulties, or who'd lost a baby, who'd had a stillborn baby, or who'd had a live baby who was often doing really well but had had quite a traumatic delivery. And those groups of people didn't always fit very nicely into, or didn't always meet eligibility criteria for the NHS perinatal services that we had. So it was a really important service to exist. The answer is largely psychological therapies. Certainly the MTLC service in North West London that I was involved in setting up is entirely a psychological therapies service, but combined with specialist midwifery. So I guess it's that kind of way of building a service that I think is important, whatever you're doing in mental health. So having the physical health and mental health absolutely together in the same service. So having those specialist midwives working alongside the psychological therapists and psychologists who were doing trauma therapy was a really key part of how those services work. Now in London Psychiatry Clinic, we have a range of our team who do this kind of work. So a mixture of psychiatrists, including me, some of our psychotherapists and psychologists, particularly specialise in women's health and around fertility and pregnancy. And it's really, like any illness, I suppose, tailored to the individual and what their life experiences have been, other traumas that they've experienced or other illnesses that they've had in their life. Yeah, it's very, I suppose, individually tailored. But yeah, really important. And there's an element to having a baby that should be seen as entirely normal. It's not an illness. On the other hand, I think saying that can sometimes minimise what some people have been through in terms of the trauma, and traumatic deliveries can mean that people don't have a second child when they had planned to. They can absolutely change. It can absolutely change the course of someone's life and leave them with symptoms that are essentially like a post-traumatic stress disorder. So really important bit to focus on.
Yeah, thank you. Can I just move the conversation on, because I'm conscious of the time, and I wanted to ask you some questions around risk management, because that's obviously a large part of what we do at Altair and my involvement in that as well. So it just seemed to me that there were a few areas that it would be really helpful to get your views on. And the first one is in relation to patient confidentiality. And we touched on that earlier, but in psychiatry, as in all medicine, maintaining patient confidentiality is obviously paramount. Yet there are situations, aren't there, where disclosure is necessary, such as when there's a risk of harm to a patient or to others, or other legal obligations arise. And I just wanted to ask you how you navigate these challenging situations while adhering to the data protection laws and preserving patient confidentiality, and what steps you take to balance the ethical duty of confidentiality with the need to protect your patient and also the public.
It's a really great question. So as I was saying earlier, I always start with this, actually. I think it annoys some people, to be honest, but I always start my appointments with an explanation of what I'm going to do with the data that people give me before they tell me anything. Because I think one of my golden rules is I never want to make any promises that I can't keep. So I always want to know, for people to know where they stand, I suppose, before they tell me anything. So I start by telling people, I tell people about our computer system. So literally where we write our notes, and there's kind of security around that. So I start by telling them that we don't write handwritten notes. We don't have cupboard fulls of paper notes somewhere. We keep it all on a computer that's appropriately protected by two-step verification and that sort of thing. And I tell them that we actually have a really great system that has a patient portal. So patients can log in and see virtually everything that I can see on the computer. There is one section of our computer record, a note section, where I can write third-party information. And I explain that to people. So I say, if someone in your life phones me up and says, if X, asks you, I never told you this, but I really must tell you that X, whatever. So there is a section for third-party information. I tell people that that exists and that they can't see it. And that if they make a subject access records request, they won't be able to see it either. In some ways, people in our clinic can see everything. So there's no point in making a subject access records request, but they could do. So I tell them all about this. And then I say, and it's one of my absolute bugbears, you sometimes hear I used to teach in medical schools with communication skills training. And you sometimes used to get communication skills trainers teaching medical students this, to say something quite reassuring like, it's all confidential between you and me and the walls or something, which is my absolute bugbear, because that can never, ever be a promise that we make. And of course, it's extremely rare to break confidentiality. I always tell people, and I think it's still true, that the number of times that I've broken confidentiality without telling the person that I'm going to break confidentiality about first and talking it through with them. So I've done it much more where I've said to someone, look, we need to talk this through, but I need to involve X because that's going to keep you safe from this horrible thing happening. But let's do this. You can't change my mind about this. I'm going to do it, but I want to tell you first. So usually it'd be that way around. I always tell people that it's less than on one hand the number of times that I've broken confidentiality without telling the person first. And I think that's still true. So it's extremely rare. And I tell this to patients before they tell me anything so that they know what to expect. That's the main way that I deal with it, so that people are absolutely, all medical information is sensitive data, of course. But the reality is that I think people are less bothered about people knowing that their leg's broken than that they've got depression. I think that is true. Of course, legally, they're equally sensitive bits of information, but not in terms of how society sees it or in terms of how people see it. So no,
it is a different, it's the same level of sensitivity legally, but in reality it's different.
I think one advantage we have as a clinic, I suppose lots of the advantages we have as being a bigger clinic, is that lots of people in the private sector are working fairly individually. are fairly alone. So you might be renting a room in a Harley Street clinic, but you're pretty much a person by yourself, being a psychiatrist in your own private clinic. Lots of people work like that. We're obviously a big multidisciplinary team, so we have structures in place like a case discussion panel where we can discuss things like, should I break confidentiality in this case? So we have a weekly discussion panel where clinicians can bring cases and discuss them with myself and the other associate medical director for children's services, the medical director, the practice manager, and we make a joint decision if we're going to break confidentiality and really justify it, and obviously justify it in writing. So we're obviously documenting those meetings on our clinical record and really thinking through what are the reasons for doing this, why are we doing this. We'd often involve yourselves if we're going to do something like that. That has a big implication as our clinic insurers.
I think that's really good practice, actually, to have that discussion, but also to document it as well, and so that there is a record of the reasoning at the time behind any decision of that nature.
Yeah. And as I say, in most of the cases I've ever done it, we've talked to the person first, because that's usually possible to do safely.
Yeah. And can I just ask you, whilst we were talking there about documentation, how you ensure thorough documentation in your practice, and what are I think you probably more or less answered this actually, but what steps you take to ensure that treatment decisions are properly documented, so if in the worst case, they're later questioned, or there may be a legal case or whatever it is, a complaint, you have that sort of decision-making process properly recorded.
Absolutely. So we, as I said earlier, we don't keep any paper records anywhere. We don't have cupboard fulls of clinical information on paper anywhere. So we're entirely paperless, and we use clinical record system, which the clinicians are expected to write a note onto the system for every time that they see a patient. For many of our clinical interactions, most of our psychiatrist interactions, so when you see a talking therapist, when you see a psychotherapist or a psychological therapist, they wouldn't standardly write a letter to your GP every time that they were seeing you, because they're often seeing you once a week, twice a week even, or once a fortnight. So I don't think there's a GP out there that would want a letter every single time. And also, there's a level to which the GP doesn't need all of those details those very, very personal details that you've shared in therapy. What we would expect our therapist to do is write a kind of summary letter to communicate with the general practitioner or anybody else involved about every 3 to 4 months or so, just to say, I'm continuing to see X every week, and these are the kind of topics we've talked about broadly. For our psychiatrists, obviously, they are doing things like changing medication or kind of things like that need to be communicated. So they'd be more likely to be writing a letter every time that they see the patient. But we'd expect all of our clinicians to be documenting on the notes part of our system every time that they see a patient. Our system, I think one of the things we're currently grappling with is whether to add a specific risk assessment, mental health risk assessment section to our note system. We use a note system that was originally designed for other kinds of private medicine, so orthopedic surgery and things like that. So it doesn't have a specific mental health sort of gist to it. It doesn't have a specific risk assessment section to it. And I'm certainly very aware that the evidence is that sort of tick box type approaches to risk assessment are not helpful. They can actually be quite harmful in terms of leading you down the wrong path or kind of underestimating risk. So what we've taken the approach of at the moment is that we ask for very narrative kind of risk assessments as part of clinical notes. So there's just a free text box on our system that clinicians can write whatever they want to or like to, and we'd expect them to be thinking about risk and risk assessment during that consultation.
I guess a couple of points on that from a sort of medico-legal perspective would be, yes, there is an element of defensive medicine to all of this, really. But my personal view is that if you do have a box in the records, that does at the very least, prompt the clinician to
I think that is true.
to think about that and to record something there. And I think in terms of if these things do develop into legal cases, you essentially live or die by your records. And if it's not written down from a legal perspective, it didn't happen, or it's vanishingly rare that a court would say, I accept that this particular discussion was held, or this particular advice was given, or this treatment was provided, but it wasn't recorded. So I think, it is probably a good thing to have a review of that and see, just to act as the prompt. Thank you very much for that. Can I just ask my last medico-legal question, this slightly sticky bit of the podcast, but just around capacity, because assessing a patient's capacity to make informed decisions is obviously a vital part of psychiatric practice, particularly for those with more severe mental illnesses, cognitive impairments, and so on. And maybe this was more of something that you were doing when you were in the NHS than you do now, but just generally, how do you or did you approach these assessments, and what criteria do you use to determine whether a patient can properly understand, retain and weigh information and make an informed decision about their treatment?
Yeah, you're absolutely right in saying I used to do more of this work before. I still am an approved clinician under Section 12 of the Mental Health Act. And in the emergency department, I was seeing people who lacked capacity to decide on what happened in terms of their mental health treatment all the time, every single day of my working week, because people were often really unwell in A&E. And I would have done a full mental health assessment, which included establishing their understanding of what was going on in terms of their illness, whether it had happened before to them, whether they recognised this as being a relapse of what had happened before and believed it to be, whether they were remembering information that I'd given them about different options for treatment and could retain that for enough time to have a think about it and tell me what they wanted. And we obviously would have looked for that kind of weighing of risks in them being able to talk about it. And I don't think you need to be able to remember it the next day, but you need to be remembering it for a good 10, 15 minutes in order to have that discussion meaningfully, which is obviously very much kind of case by case and doing that. And we would have tried to use I think this is often the tricky bit in A&E, is trying to use every bit of help that we could do for the communication bit of it. Often the really, really tricky bit in A&E in London was translation services, actually. So we would often language line or a service like that, which is on a two-way phone line where the translator's sitting somewhere, I don't know where, on the end of their phone, probably working from home, and you're trying to talk onto a phone, and the patient's trying to talk into the phone, or their relatives trying to talk into the phone. That was often quite a tricky bit in A&E in London, because people come in obviously speaking all sorts of different languages, of course. And I wish I could say that I spoke lots of languages, but I don't. I only speak English. So that was probably, the communication bit was probably the trickiest bit to facilitate. But yes, I was doing that work all the time, because of course that was really key, often about whether people could decide for themselves to be in a hospital voluntarily, or whether we needed to consider a detention under the Mental Health Act. That was the commonest reason that I was looking at things. Now at London Psychiatry Clinic, the vast majority of people that I'm seeing absolutely have full mental capacity to decide on what happens, and they wouldn't be with me otherwise, because you have to have joined a video call and have done quite a lot of active things. So we are looking at building at the moment in London Psychiatry, we don't do any older adult psychiatry around dementia, and that's one of the next bits of the business that we're looking to build. So of course then we will be doing this sort of work a lot more. Absolutely. And then it brings in longer term kind of capacity around, for example, making a will or things around dementia. So we're just looking at recruiting the right people to come in to start doing that sort of work. At the moment, we would very much direct it to other companies.
And can I just ask on that, as the Associate Medical Director of the London Psychiatry Clinic, you have over 50 individual clinicians as part of that service.
Yeah.
And how do you ensure that there is a consistent quality of care and a consistent I guess there's many diverse approaches and specialities within such a large team. So how do you manage that and ensure consistency?
Yeah, it's one of our major discussion points that we're always having. So I think we're very much on a journey from being essentially a group of friends who all knew each other and started working together as a business to being a moderately large clinic. Actually, in the private mental health setting, we are amongst one of the largest clinics actually now. And absolutely maintaining our brand, which is that we provide exceptionally high quality and very individualized, bespoke, very concierge-like services. So we'll go above and beyond what you would be expecting in a kind of NHS service. Has always been our brand. Otherwise, I don't think we could justify what we're charging people. So, of course, that's what we want to do. And I think that becomes one of our main challenges, is maintaining that when you get lots of other people on board. I suppose our first step is making sure that we're recruiting the right people. All of our clinicians work on practicing privileges. So they're all essentially legally self-employed. But that doesn't mean that we don't go through a very rigorous process of all the usual things like getting references and DBS checks and all of those normal things that you have to do. But we're also sort of selecting people through an interview process that we think are going to work in a similar way to what our brand is. We have then regular reviews of people's practicing privileges. So you're not sort of in and then never reviewed. So even though I'm nobody's line manager per se in a kind of legal employment sense, because people are self-employed, but of course we're all doing clinical work or coaching. So we're all dealing with people. And so there's a blurred line there between being employed. I mean, when nobody's employed legally, but we're all doing things which need supervision. So I have regular meetings with all of our clinicians to kind of talk through how things are going for them and whether there's other stresses going on that might be affecting their work, all the normal things that you'd expect from a NHS service where people were having supervision. We do that too. And then obviously it's about having policies and procedures written so that people are clear in writing what we expect, and the induction process. So when we get a new person in, it's important to show them where all those policies are and make sure that they've had time to read them and ask questions about them. And then for people who've been around for a long time, make sure that we're reviewing
ongoing training as well.
So, I mean, there's loads of advantages in that of being in a bigger clinic. So we have enough people that we can sustain things like our complex case discussion panel that I spoke about earlier. We also have regular monthly CPD sessions, so teaching sessions, which our clinicians can attend. And we either have one of our clinicians speaking, because we have lots of different experts, so we'd be silly if we didn't use that, but we also get external speakers in to give talks. So there's kind of bits of the structure of being a big clinic that help us to maintain things, as well as making it a bit harder to make sure everyone's doing as well as everyone else. But those are the things. And obviously things like audits, regular audits of what people are doing, reviewing complaints when they happen, because of course we get complaints. I think it would be worrying if we didn't, as if we didn't have a process or we weren't open to them. So of course that happens, and we have a very robust procedure for looking at those and learning from them.
Yeah, fantastic. Thank you. Well, thank you so much for being such a great guest and talking so eloquently about all of those aspects of your practice. Before I let you go, there's one thing that struck me from reading your resume, was that you are someone who has a passion for music and festivals. You've been attending Glastonbury almost every year since your 20s. And you've described it as realising your lifetime ambition when in 2016 you started voluntary work as a liaison psychiatrist at Glastonbury and at Reading Festival for Festival Medical Services. What has that experience been like?
Great question. I should say, first of all, sadly, and it's busted my lifetime ambition, I've had to give up because one of the rules is, unsurprisingly, an extremely popular volunteer job to do in psychiatry. So one of the rules is that you have to be an NHS consultant, which I am not anymore. So I have stepped out of it, although lots of family and friends still work for Festival Medical Services, which is an amazing charity that were born out of Glastonbury. One of the psychiatrists there has been doing it for nearly 30 years. And since he was a junior doctor, and he kind of help build the service. Essentially, what they do in both festivals is use a couple of wedding marquees, literally like you would use for your wedding in your back garden, if you had a big enough back garden. And in Glastonbury, it's the wedding marquees are put at the top of the pyramid stage hill. So the hill that you see in all the TV programmes, where the big main stage is at the bottom and there's this sort of natural amphitheatre. The Worthy Farm, the main farm buildings are at the top of that hill. And in front of the farm, there's enough space to put this marquee, and they essentially build an A&E, an emergency department. So predominantly, obviously, they're dealing with people who've sprained their ankle or I don't know what else, everything else. But there's a psychiatry part of that tent. And it's liaison psychiatry, just like I was doing in the NHS in the emergency department. So it's just liaison psychiatry, but in a tent instead of a building. We obviously got a lot of drug-induced psychosis there. That was a big thing. Festivals generally are extreme. I mean, I love them, but they're extremely overstimulating places to be. They have all of the recipes, all of the best recipe for getting mentally unwell, especially if you've got pre-existing conditions. So you are highly likely to forget or lose your medication. And that happened all the time. You don't really sleep, because even if you try to go to sleep, it's really noisy, and you're probably out partying. You're probably drinking more. You may be using drugs. You're probably not looking after yourself in the sense of eating very regularly or drinking enough water. So it has all of and it's just totally overstimulating. It's fun, but there's never a quiet moment where you can kind of reflect or relax. So they kind of have the perfect recipe for getting ill. Reading is a very different cohort of people that go, very different demographic. It absolutely, I mean, the stereotype is when you've finished your GCSEs or your A-levels, but it is full of people who are between 16 and 18, usually very naive to, or very, very much having their first festival experience. So, and often using drugs for the very first time as a very experimental thing. We used to get kind of big groups of people, most of them fine, but with one person who'd had a really bad reaction, and the rest of them very, very scared, and usually asking us to call their mum and dad. So we did a lot of calling mums and dads. Yeah. Glastonbury is very different because it has a whole age range from babies to, I mean, my parents still go, so in their 70s and 80s. So you get a much more normal range of kind of illnesses. So the A&E might be dealing with heart attacks or anything that might have happened anyway. The most interesting story I've got from Glastonbury, because it's just a good story that is pretty anonymous and would never, ever have happened in my usual job, is I don't know if people went to the Viva La Vida Coldplay tour that was a few years ago, where they were, in fact, they did it for the one this year as well, didn't they? But that year also, they gave everyone in the audience these free wristbands that lit up in time to the music. And I was actually working the shift that night. And obviously I was in this tent that was at the top of the pyramid stage, and you can still hear the music, not that loud, but you can hear it. And of course, everyone loves a freebie, even the doctors. So we'd all got these wristbands on our wrists, even though we were working. And this man came in who was absolutely convinced that one of the DJs had stolen his thoughts and ideas, which is a very typical symptom of psychosis, that the DJ had sort of got into his head and was stealing his thoughts and broadcasting them through the music. He thought it was one of the DJs. Another great bit of Glastonbury that year was a place called Arcadia, where they'd built this amazing metal structure that was like a huge spider with these arms, sort of metallic arms coming down, 8 of them, and sort of trapeze artists and fireworks coming off the arms. And the DJ was right in the middle of the spider. And underneath it is just people dancing, a lot of them using a lot of drugs. So it's the perfect storm for kind of thinking that maybe the DJ is stealing your thoughts. And this man came in to the thing and, you know, we're having this conversation, and I am being my usual self of being very open-minded and saying, well, maybe that's happening, and, you know, let's explore it and tell me a bit about it. Has this happened to you before? And then suddenly Coldplay started playing, and everyone's wristbands started flashing in time to the music. And he said, see, I told you, look look at that as proof, and that's never going to happen to me in any other sense.
Probably not.
Yes.
Probably
so that's my best sort of.
Oh, fantastic. Well, thank you for sharing that with us. And thank you again for being such a fantastic guest. It's been a real pleasure and a privilege to talk to you this morning. And thank you very much for appearing on the podcast.
Thank you for having me.
Thank you for tuning in. I hope you enjoyed today's episode of Altair Talks. If you did, please don't forget to subscribe or leave a like or a review on whatever platform you're listening on, as this helps spread the word. If you have any questions or comments or topics you'd like us to explore in future episodes, please do contact us, as we'd love to hear from you. You can find us on LinkedIn or visit our website at www.altairinsurance.com. Stay tuned for more episodes, and until next time, take care of yourselves. The information contained in this podcast is not intended to represent a complete analysis of the topics presented and is provided for information purposes only. The views expressed are personal to Dr. Ashby and Will Marshall and do not necessarily represent the views of the London Psychiatry Clinic or Altair Insurance. The content of this podcast is not intended as legal advice, and no responsibility can be accepted for any reliance placed upon it. Independent legal advice should always be obtained before applying any information to particular circumstances.